Right. Good morning, everyone, and welcome to session 3 of our RaCEEs course. Today's session is about costs, and we will go through some information around cost data, resource use together, and also we will talk about how to extract this info from your papers. I just want to thank Luís for co-running this session with me today. And as always, the session will be recorded, will be made available on the Arc Nord West Coast YouTube channel. And if you have any questions about the recording, please let us know. Right. Now, last week we gave you some homework, which was a table basically where you have to fill in some info on the key attributes of your economic evaluation. I know that it could be a bit challenging because unfortunately there's not a standardized way to report economic evaluation, or there should be, but not all the authors follow the standard way to report information about economic evaluation. So some elements might be found, some elements might be missed. So I know that for some of you it might have been a bit of a challenge to find some information, but don't worry, it's just an exercise. It's just, the objective was to familiarize yourself with the different elements and yeah, to try to capture as much information as possible. Now, before I start actually the session 3, do you have any questions on the homework from session 2? Okay. So if you have any questions, of course, you got your team leads available. If you have any doubts, or if you want any feedback on the tables you filled in, you can ask your team lead to have a look at the table. And the same for the following session for future homework. So we're always here available for you if you need us. Now, today's session is about costs. So this is the timeline for our RaCEEs course. So we are still within the method section. So in session 2, we try to capture information about the key attributes of economic evaluation, and then we will try to write that up in our method section of the commentary. So we are still within the method section of the commentary, and today we focus on costs. And then this is the different subdivision into the sections of the commentary. So we focus on cost data today, and next session will be outcome data. Then we will move on to the results later on. So today's aim is to identify and describe the characteristics of the cost data used in the economic evaluation. We will talk about different concepts which are all kind of interlinked, and they're all related, of course, to cost. So we will talk about total cost. Then Luís and I will talk more about resource use. Luís will talk about unit costs. And then I will conclude the session talking about currency and price here. And we will try to provide you some examples about all these concepts throughout the sections. Now, you might be bored of seeing this figure. This slide is a typical simplified example of an economic evaluation where you have this choice between two alternatives. And from what we learned in session 2, we now know how to describe the alternatives in terms of whether they're, for example, pharmacological, psychological interventions, how they work, where they took place, and the sample as well. So we got some information regarding the whole design of the economic evaluation, like the time horizon and perspective. Now we're going to focus more in depth around some particular segments of the economic evaluation. In particular, today we'll talk about costs. Session 4 will be about the consequences or the outcomes from the different alternatives. And I want to start today with talking about total cost. So the total cost naturally will be expressed in monetary units. And with total cost, we refer to any expense or how much the intervention cost. And that could be medical cost, non-medical cost. So we are trying to group all the costs together and trying to add up these different costs. Now, in a paper, you might see the overall total cost from an intervention, but you also might be able to see different categories of total costs. So, and I will show you different types of costs in a minute. So there will be different total costs reported in a paper. As I was mentioning, total cost, as you expect, is something that authors are going to report in monetary units, so using a particular currency, and is the multiplication of resource use and unit cost. Now, resource use is something that authors express or report in natural units. Unit cost, again, is something that is going to be reported in monetary units. Just to give you an example, let's suppose that, for example, tonight you have to host some guests, right? And for dinner, you have to, set up the table, you need cutlery, plates, and so on. Resource use is the number of plates you need. It's the number of forks you need, the number of spoons, okay? Just the number. So we're not talking about money yet. So you might need, I don't know, 6 forks, 6 spoons, and so on. The unit cost is how much each fork, each plate, each spoon will cost you, okay? So if, let's say, a spoon will cost you £1, just as an example, and you need 6 spoons, £1 times 6 spoons, the total cost for the spoons will be £6, okay? So you will see, you're able to see that it's probably quite straightforward to calculate total cost, and it doesn't involve a lot of complicated mathematical calculations. And usually, I will say, is something that researchers can estimate and calculate in quite an easier way compared with other elements of an economic evaluation. And now we're going to focus on the different components of total cost. So we start with the resource use, and then we'll move to unit costs with Luis. But before we do that, I want to describe the different type of costs that you might see in your paper. So these are terms that you might be able to see in your paper or in other reports or in other literature. So it's good that you can familiarize with these terms in case you wonder what they mean. There are different types of costs which authors, researchers capture in an economic evaluation. And we'll start with direct medical costs. Direct medical costs are strictly linked to the provision of healthcare. So here you got a few examples. This is not an exhaustive list. It's just to give you a sense of what we mean with direct medical costs. So things like generic care, for example, inpatient care, outpatient care, urgent care, but also things which are probably more detailed, like medication costs, consultation costs with different health or social care professionals, treatment procedures, test, rehabilitation. So everything that might be linked or strictly linked to the provision of healthcare. Now, unfortunately, not all papers will report specifically and in depth all these different elements. You might have a number which describe the whole direct medical costs overall, and if you are lucky, you might have different costs for the different elements as well. So unfortunately, that's not always the case. But if you have a look at the results section of your paper, the tables should have some indication around direct medical costs or total costs from an intervention. Direct non-medical costs instead are costs which are broadly linked to the provision of healthcare. And I'm going to give you some examples here. So you can think about travel costs, accommodation costs, food as well. So things that the patients, the families, or the caregivers might need to incur in terms of receiving care, so travel costs, accommodation costs, but also things that might be outside the healthcare setting, like home modifications, for example, if the patient needs a walk-in shower as a result of being ill, or other items which might help with the recovery of the patient, like books or apps. So these are non-medical costs, direct non-medical costs, and then we move aside the health or social care spectrum, and we talk about indirect costs. Here, instead, we talk about any lost income for the patients, for the families, for their caregivers. So of course, typically a patient will not be able to work for some time, and they would lose salaries after a certain point. They will lose work days, and the same for families and caregivers who provide care to the patient. And linked to that, you will have productivity losses, which the employer might have to take into account in terms of recruiting temporarily or permanently a member of staff. So we are trying here to consider costs which are outside the healthcare or social care system, which might impact on society more widely. And this, as you probably have guessed, this is linked to the perspective of the economic evaluation, which Luís will talk a bit more about in the next slide. Okay, I'll stop sharing. And do you have any questions so far? Okay, Luís.
Sorry, Valerio, can I jump in and just ask a question, please? With regard to costs, has everything automatically been ascribed to cost insofar as something like intubation? Is there a set NHS list or whatever for how much an intubation costs? Is there something that people can refer to be able to quantify every direct and non-direct medical cost, for example, in terms of money?
Yes, there is, and Luís will talk about that in a few minutes. So yeah, that's a great point, and Luís will cover that.
Oh yeah, I'll show you just a simple example, not in terms of intubation, but yes, there are the so-called unit costs that people compute. So researchers compute in order for then other researchers or whoever wants to use them to be able to assess them and to compute unit costs. But okay, I just noted that I was talking and I was muted, so you were not listening to me. So it doesn't matter how long we are doing this in Teams, we always do these mistakes. But okay, let's go to resource use. So I think, why is this not switching? Okay, let me. Okay, it is now. So in terms of resource use, Valerio basically already explained you a little bit. It's exactly if you are going to have a dinner, the amount of units of spoons, forks, etc. that you need to do. So if you just want to put this in terms of healthcare, of a certain service in healthcare, it is going to be, for instance, the use of healthcare staff time, facilities, consumables. Of course, you are going to relate to medicines, which usually are needed. So that's basically it. You need to count for a certain intervention, for a certain service, a certain treatment, what are all the resources that you need to use in order to make that happen. I'm having struggles here with, okay. So this, whatever you want to count, and this is going to be important when you go to the unit costs, it is going to depend on the possible perspectives. So I think if you remember last week's session, we also talked about perspective, because they are going to matter not only for the costs, but for the benefits, just that today it's about costs. So you may have, for instance, the patient perspective, where the patient will care about the amount that the patient pays. So in here in the UK, it would be the amount of out-of-pocket, if you have any. Most of the times you don't. You just go and you don't pay anything. But if you have any out-of-pocket payments, then that would be the amount that the resources that cause that out-of-pocket payment are going to be the resources that are relevant to the patient. Then you may have the payer, and you may have the healthcare. Sometimes these are very similar. For instance, here in the UK, they will be mostly indistinguishable. But if you are talking about the US, and if you find a paper from the US, you may have, for instance, the Medicare. And Medicare is a payer, so it's not the one that is delivering the services. So Medicare is going to care about the resources used in the part that they are paying. And again, they don't pay everything, because you may have some part that is paid by Medicare, and then you may have some part that is paid by the patients, again, out of pocket. Now, the healthcare service as a whole is going to care about everything, the part that is paid in out of pocket by the patient and the part that is paid by the insurance companies, Medicare, Medicaid, etc. And then you have the society, and the society is, the sky's the limit, is whatever you want to put in there. So for instance, you may think about of resources of a certain type of intervention. Let's say that you need to go to the hospital for a surgery, and you may count the things that are needed for the surgery. But maybe for the society, again, you may count other extra things. So for instance, the cost of traveling for the patient, the cost of traveling to the hospital. Valerio was talking about, this is more for the cost and for the resources really, but Valerio gave you the example of if you lose time in working, those are going to be costs that you will want to measure as well. So yeah, everything that you can see that an intervention, service, etc., can impact on the life of the individuals or of the society. Now, Valerio already gave you that. So commonly recorded items of resources use are usually visits to GP, specialist visits, hospital admissions, hospital bed days, medications administered, etc. So a lot of the times when you are trying to, in the context of an economic evaluation, when you are trying to compute resource use, you probably will see whatever has been used in randomized control trial. Imagine that you have a new intervention that you want to test, and there was a randomized control trial. You are going to count everything, the number of physicians that you had in there, the number of nurses, the number of medicines, the number of absolutely everything that you are going to use in the control trial. That is very typical. I have just a note here at the end, which is something that we need to be careful about, is that not always what you use in the trial is going to be the same when you just put the intervention in the healthcare system. So certain dynamics may change. There are things that you may need in the trial, sometimes even to monitor the trial itself, that you are not going to need whenever the intervention is out there for the general public. There may be differences, so that's just a thing that you need to be concerned about. Now, I just wanted to do a very quick exercise with you, which is, let's just say the following. Let's say that, let's consider simple surgery, appendicitis, doesn't matter, simple surgery. How would you list the resource use? What things would you list in an appendicitis surgery? If you care to participate. So, anyone?
You see,
yeah, thank you. So there are the consumables like the anesthetics, the instruments, and any drugs used at all, and the staff time, and that would be broken down, I guess, into surgical hours and nursing staff hours and things like that, which have different implications. Bed usage. That's just a few things off the top of my head. Sorry.
No, yeah, that's just what I want, because believe me, you will know that a lot better than us. Yes, please, Patricia.
Yeah, I was going to say exactly as Hilary said, in addition to like hospital stay, the beds, the days that this person would still be there, the medications after the operation, any kind of painkillers. So there are a lot of costs involved, I would think.
Yeah, I agree.
Yeah.
So I think Will was first.
Thank you. I suppose it's how far you want to take it. It's all of the perhaps non-direct costs, so the estate costs for using the premises. It's all the administrative costs in advance, potentially some pre-op assessment as well. So it's following the whole patient pathway through. So it's whether or not we mean just the appendicectomy or all of the pathway before and after.
Yeah, true. Which sometimes it's also going to depend a little bit on the perspective a little bit. If you go for a societal perspective, sometimes you broaden a little bit the time frame, because there are other things that you'll care about. So we had Trevor as well. No, Trevor, not sorry, Terry.
No, I was just going to add to that, and I think the last speaker made a good point. How far do you want to expand this, or how far should one expand it? Because loss of income for the patient, loss of income potentially for carers, any particular costs that are incurred looking after the patient post-hospital visit, all of these things are costs, and that would be in sort of resource use. But you can just go on, and I'm not quite sure where the boundary would lie.
Yeah, okay. I think that is going to be a little bit of a matter of perspective. Valerio, if you want to come in, please do as well. But I would say that if you care about the healthcare only, so if it is the healthcare perspective, you are probably just going to compute all the costs that are related to the provision of the service. So you need, like you already said, you need the doctors, you need the nurses, you need all the costs with medications. Probably you need to compute, no, it's not probably, you need to compute also the costs of the space. So the space has a cost. You can even go to put energy costs if you want. Those are tricky because you need to do imputations, understand what amount of energy is, because you are usually in an hospital, right? So if you are paying the lights, for instance, or everything, you need to understand what you should input to a specific intervention, surgery in this case. But you can compute everything that you spend in the hospital, and you can try to input each bit of your spending, each bit of your cost to certain interventions, and that's what they usually do, and that's how you are going to compute the unit costs, for instance, for an appendicitis surgery, for example. Valerio, do you have anything you want to say?
Just to add that, for example, when we conduct a study in the UK, we follow guidance from the National Institute for Health and Care Excellence, so NICE, as you know. So they recommend to use the health or social care system perspective as a minimum. Okay, so that's the minimum. Okay, if you want to span that, consider society. That's an a plus, but as a minimum, of course, health and care system cost should be considered there.
Yeah. Let me just say one last thing, which is the society one, I think, is one that is still growing, because the typical thing is to consider the healthcare. And now I think people are expanding on the society one. And typically they go for more obvious things still, like caregiver time, for example, informal caregiver, things like this. Even the part of the time that the patient loses in terms of working is still debatable, because there are some people who are going to say, oh, but that's for the labor market part, so it's not for the health market to pay. So it's a little bit tricky, but it is expanding, and it's definitely something that is still in debate. The society part, it's still being debated a lot. So let's see how it evolves. But it's like you said, the sky it's a limit. The sky is the limit. So it depends on where you want to stop. Yeah, please, Patricia.
Yeah, I know this is a little bit off topic, but it would be interesting to see the difference between the costs in public hospitals and the cost in a private setting. How would it be like? Because a few years ago, my son had an urgent emergency appendicitis back in the UAE, and I had to be off work for 10 days. I was with him in hospital for 10 days. So can you imagine the costs? But I didn't pay anything. I mean, it was private, but it was through my work. But I would think maybe in a national hospital would be like maybe you go in, you go out, or something like that. So the cost would be different.
Okay, I'm going to try to answer that very fast. For the payer, usually private is probably more expensive. Yeah, because you need to pay. You don't pay if you go to the National Health Service. But for the provider, I think it depends. I don't know. I don't want to say anything that is problematic, but I would assume that sometimes maybe people will argue that private can do it more efficiently. Sometimes I think it's not. Yeah, I'm going in a direction that is dangerous, because I don't think that is always the case. I think it depends a lot on a lot of things.
Okay.
So yeah, it depends a lot. Yeah, I'm not going there. Okay,
Thank
let me continue. So Valerio, sorry. Okay, I'm having trouble skipping slides. So Valerio, can you?
Yeah. Thank you, Luis. So this is just a slide talking about how we collect data about resource use. I will say that typically in a research paper, you don't see a lot of sentences, a lot of space dedicated to this, and it's something that actually takes a long time to do in practice, to design and to actually collect data on resource use. If you're running, for example, a clinical trial and you have the opportunity to collect first-hand data from the patients through case report forms or CRFs, through patient questionnaires, through diaries. So there is an opportunity to collect data around, the medical condition, the medical history from a patient, but also about resource use. Now, this method come with pros and cons. For example, patient questionnaires is when you actually ask the patient to fill in a table or a form regarding their resource use in the last month, 3 months, 6 months. And as you can guess, the more you ask patients to fill in a questionnaire, so it could be one questionnaire month 1, one questionnaire month 2, month 3, it will become a burden. Okay, so they will be less incentivized to fill in questionnaires the more you give questionnaires to them. At the same time, you need to consider that if you want to have fewer questionnaires, so let's say you got a questionnaire a month 6, and they will need to remember what they used in the last 6 months, that could become a challenge, okay? Especially if you are dealing with a patient with cognitive issues, for example. They might not remember how many appointments they had, or they might not remember the type or number of medications they had. So there is a trade-off between frequency, burden, and of course that will impact on the ability to remember things and what we call recall bias. The same for diaries. So diaries instead is a more prospective way of collecting data. So we ask patients to keep a log on the type of resources they consumed. And again, that could be depending on the ability of patients to remember to keep a log, which is, might not so much of a certainty. So all these methods come with pros and cons, and that's why it's important to validate or complement this data with the use of, for example, electronic health records, which report the medical history and treatments had by a patient, but also studies in the literature. There might be other studies which looked at that particular condition which you're interested in, and they might have reported the resource use from the patients having that particular condition. Data set with NHS data, GP data, hospital services data, but also public sources like guidelines. For example, guidelines might indicate the number of appointments a patient with X condition needs to have in the first 6 months, 1 year. So there is an expectation around the type of resource use a patient might have in the first 6 months or 6 years or a year after falling ill. And yeah, that's it for this slide. Thank you, Luis. I think you need to mute yourself, Luis.
Yes, I'm still struggling with. I'm not sure what's happening. I think every time I click elsewhere, then I cannot skip slides in here. So, okay, there's just a tricky bit with the animation here, but okay, let's put everything here. So, okay. So we talked about resources. So now what is the unit cost then? The unit cost is going to be the total expenditure incurred. So it can be used in anything. It doesn't need to be in healthcare. So it is the total expenditure incurred by a company to produce, store, and sell 1 unit of a particular product or service. Now, if we are talking about healthcare, it depends on the unit that you are considering. Let's say that it is a service where you have only the physician that needs, it's just a GP consultation. Probably it is going to be only the time that the physician needs in order to do that consultation. So let's say it is 1 hour, then it's probably you just need to count 1 hour of time of that particular member of staff, in this case the physician, the GP. Now, in the example that we gave before, things may become slightly trickier. So we were talking about the appendicitis, right? And you were talking about that you are going to need, in order to do a single appendicitis surgery, you are going to need the nurse, you are going to, or several nurses, the physicians, you probably need the physician to do the surgery, you need another one to do the, I always forget, but to take the drugs to sleep, to give the drugs to sleep, you probably need the room, you probably need the electricity, you need cleaning, you need the room for more days for the patient to get better, etc., etc., etc. So what you need to do is to try to understand what is the average average expenditure to do an appendicitis surgery. And look, they will change depending on the patient, the needs of the patient, sometimes even depending on the physicians that are doing it. They may cost a little bit more or less. So what researchers are going to do in general, they are going to try to compute an average and try to understand what is the average cost of that procedure, of that service. But you do need to put that everything together. So the unit costs are going to really depend about the unit that you are choosing. If it is a service that has several things in there, you need to compute the average of that. So I would disagree with something that Valerio said in the beginning, that it's intuitive. It's a little bit simpler. I think sometimes it depends, because there are some costs that may be a little bit trickier to estimate and maybe a little bit trickier to get the correct average. But yeah, intuitively at least they are. Now, there is another thing that I want to talk to you about. I think this first part is more intuitive, but there's the second part which is a little bit trickier, which is sometimes the costs they are not as directly identified. So there is a concept that I like to call the god of concepts, or the goddess of concepts in health economics, which is the opportunity cost that may be really useful in some situations. So technically, whenever you compute the cost, you are basically computing an opportunity cost. Doesn't matter, but I'll give you something for you to think. How do you compute the unit costs of informal caregivers? So it's tricky, right? Sorry, I didn't want to skip. It's tricky. How do you compute the unit costs of the informal caregivers having to step in or out? Maybe you just want, it depends on your problem, but how do you compute that? And in here, you will need to understand the concept of opportunity cost. So the opportunity cost is the following. Whenever you make a decision, any decision, doesn't need to be in health. Let's say you go to the supermarket and you want to buy something to drink. And let's say that you want either beer or wine. You only have money to buy one of them. You cannot buy the two of them. So if you decide to buy beer, you don't buy wine. If you decide to buy wine, you don't buy beer. Now, the opportunity cost is whatever you give up when you make a decision. So if you decide to buy beer, your opportunity cost is that you don't drink wine. So that's the cost, is not having access to wine because you decided to buy beer. If you do the opposite, of course, if you decide to buy wine, your opportunity cost is beer, the beer that you don't get. Now, in terms of anything that applies to healthcare, it can be the same. So whenever you need, for instance, an informal caregiver to step in to help with some treatment, what are you losing? Okay, and what you are losing is the productivity of that informal caregiver. Were those people doing anything else? So let's say that they could be working and they need to stop working because they need to provide care. Okay, then what is the value of the work that they would be doing if they were not doing the caregiving activities? So if you need at some point in economic evaluation to compute some costs for informal caregivers or any other costs that are not as directly measured, that you don't have money, that is not intuitive what is the amount of money that you get, you need to try to understand the opportunity cost. One of the things that you are probably going to use for informal caregivers is the salary that they give up. And you probably make this big assumption that the salary that they give up is the productivity that they would provide to the economy. So now it's probably going to be very complicated to decide what salary you are going to use, because you can say, for instance, maybe minimal wage, because if they are willing to give up working to do caregiving, maybe it's because they're what they would earn outside of care if they were in the market, in the labor market, would not be as high. But maybe that's too low. Maybe some people go for caregiving because they really need to. So maybe the average salary of a person in the UK, let's say. So that can be tricky and assumptions need to be made, but still the idea is to go for opportunity cost. So any questions so far? Irene?
Trevor, I'm using my.
It's Trevor. Sorry.
I apologise for a late attendance, but I've been trying to get this to work. One thing that you've not mentioned is the training of all these people.
Sorry? Can you repeat?
The training of all these people.
Mm-hmm.
They have to train a surgeon, an anaesthetist, a nurse, and the staff who look after them during and after any operation. That is not a small amount.
No.
And it is absolutely essential to the satisfactory surgery, satisfactory of the service. So I don't think I heard anybody talk about training, but no one can be involved in medical care without being trained. And it is not cheap either.
Yeah, I'll show you something very interesting in the next slide about that.
Sorry?
No, I'll show you something about that in the next slide. So it's a great intervention. You are totally right. Training should also be accounted for. I think Maria was next.
Yes, thank you. Just to clarify, in the case of caregivers, if you were to account for the effect of caregiving on their health, would that be a direct cost then?
Sorry, I'm not sure I understood.
So, for example, if they are becoming more depressed because of the caregiving situation, or their physical health suffers, would then that be considered a direct cost?
Okay, I would count that. You are talking about the caregivers becoming depressed because of the heavy load or the emotional load that they get. You would count that on the benefits side. So what sometimes people do in economic evaluations is when they do, for instance, a cost utility analysis. If you remember by now, cost utility analysis is when you compute the QALYs as benefits. You can compute the QALYs for the patient, and you can compute the QALYs also for the informal caregivers. And then you have the benefits, the change in benefits for both of them, where of course the change in benefits for the caregiver in that case, you assume that they are going to be negative.
So that would be more an outcome, if I understand you well.
I guess
rather
so.
than an
Yeah.
input.
I
Valerio,
think
yeah.
if I can jump in, I think, Luis, yeah, you're right. I think if you want to measure, like, I would say the disbenefit from an intervention, of course, you can measure that in terms of, quality of life losses for the caregiver. But depending on your perspective, you can capture the costs attached to, care for the caregiver. So if you are interested in, capturing those costs, I will class them as direct medical costs, yeah, because it's a care that.
In that sense, sorry.
Yeah. So
Okay.
yeah, there is a
Mhm.
the outcome side, but also the cost side.
Okay, I had misunderstood the question. Sure.
Yeah, no, sorry, I may have asked it.
No, it was
in a
good. I
confusing way.
misunderstood it.
That's what I meant. Thank you.
Okay. Sandra, please.
Yeah, you mentioned about carers that are losing their salary, but do we take into account, not that it's worth anything, I think it's worth less than a cup of coffee per hour, the carers allowance that they receive. So is that somewhere in sort of the cost? Because I know when you sort of talk about, government sort of talk about how much it's costing for carers allowance, but they don't talk about how much it's costing for the carer themselves. So is that involved in the costing as well?
Sorry, again, I'm not sure I understood
So we're talking about,
question.
so carers give up their jobs. So if their carer is on, for example, I know, £30,000 a year and give up the job, then they get carers allowance, which I don't know what it is at the moment, something like £150 a month or something ridiculous. So that is they taking into sort of the costings as well?
Yep.
So what you're talking about? You're talking about what the carer will lose, but you're not. Yeah. But you're also taking into account what the carer might.
I understood.
Yeah.
I was just thinking a little bit because we need to be careful about double counting, I guess. But please
go,
Valerio.
No, but I think it's connected to what I was saying before. Again, depending on your perspective, if you are interested in capturing the cost of, for the caregivers, absolutely, that's a cost that you need to capture. And I have to say, there is more and more interest in capturing the cost attached to the caregivers in recent years. We see more and more studies, first of all, providing guidance on how to capture this cost, and second, actually collecting data around this cost. And so economic evaluations are not anymore focused on the patients only. They are really trying to broaden the scope and try to consider the cost for the caregivers. And what you're saying, Sandra, about the caregiver allowance is something that I assume that will be captured more and more in the future studies. Yeah.
Thank you.
Okay, now I just want to show you something very, very fast. For instance, you can, I at some point in my research, I was interested in understanding what would be the cost of a carer in the context of adult social care. So you have here 3 references of unit costs. The one that I'm interested in is, if I go here, let me click. But I already have this open in case this doesn't work super well. Okay, can you see it? If you come here, you can see the unit costs for health and social care for every.
I think we can see, Luis, because it's on another window.
Okay.
You can use the slides. I think it's fine. Yeah.
Okay, then I'll use the slide. So if you let me go back. So if you click here, you are going to get into a site where you are going to see the unit costs for every single year that they compute, and then you can click download full document, and at some point you will have on your right the document to download. You click to download, and you are going to get to a document. In that document, you will have an index. And in that index, usually you can click on the thing that you want, and it is going to go directly to the category that you care about. So in this case, at some point, I was interested in seeing what would be the unit cost of a social care worker. So I can go to that one that I just told you, and here you can see the social cost of the care worker. And you can see that they are going to be detailed. So you have the salary, you have the salary on costs, you have the initial qualifications, you have ongoing training, you have overheads, you have direct overheads, indirect overheads, capital overheads, and travel. So for Trevor, you can see that you do indeed count the qualifications or training. In this case, there's nothing here in training, but depending on the category, you may also find something about training that they need. So yeah, you will see that they have all of these very well specified, and you have the notes explaining what each category means. So that's what you can use if you at some point in your life need to compute unit costs. That's what you can check. Or if you are checking an economic evaluation and you want to check if they did everything correctly, you can also try to check these unit costs to see if they go if they match what they have in there. So you can see that at some point they will give you the total costs per year. So you have it here. You know that in this case, a social worker, this social worker is 85,000 pounds per year. And then you also have usually the unit costs per hour. And you also have these two different specifications, which is with qualifications and without qualifications. Of course, the one with qualifications being more expensive. Okay. So now continuing to what you will be needing to do in this course, let's call it, how to extract the information about the resource use on unit costs. Again, we will use the same paper that we used in the benefits, the one that we did. And we can see what we did. In this case, it's a little bit more trickier. You saw in the other one that we were almost paraphrasing what they got in the paper. In this case, you will see our part. We say this: the model considered both medical and non-medical costs, including hospitalizations, emergency room visits, consultations, professional caregiving, and respite care. Health state costs were estimated using regression analysis. Professional care accounted for a significant portion of the total costs, with the cost of nursing home staff being the most significant factor. So it's a very small paragraph. But then if you go to the paper, it's already a little bit trickier. So let me just see if I can put the pen in. So this part, if you read it, it is going to be, well, in fact, it's until here. So it is going to be mostly about the cost of the medication, the direct medication that they are testing. They are going to talk about that here. Then you will see that they are going to talk about other costs. So other costs of instruments that they need that are not a medication in itself, and then they are going to talk also. Sorry, because I cannot see. This is okay. So medication costs, then other costs. Okay. Then here you are going to see that they are basically talking about this part of the regression analysis, which I'm not sure if you are familiar with regression analysis, but if you are not, there's a video that we have in our series of simplifying health economics. But okay, here it's a part where they are going to try to estimate the costs of the different health states that people can have, that the patients can have in this particular problem that we were checking. And then, sorry, and then here it's where they describe more or less the types of costs that they have with therapists, with nursing home staff. So the other things. So okay, you are probably going to need to search for that. It's not going to be as intuitive as last time. You will see that you will have these several sections. So the medication, other instruments, the costs associated with the health states, and here a little bit of information about resource use, what type of other things they are considering. So sometimes you also need to look at the tables. You will see that whenever they are talking about the costs in the text, they refer several times to this table too, where you can see again that they have the main medication, they have the other medications, then the other, let's say, instruments, materials, so tube insertion, Then you have things like the follow-up visits. You have things like per visit follow-up consultant-led, per visit follow-up non-consultant-led. You have also other things that you need to have into account is the possibility of adverse events. In this case, replace reposition tube with surgery or replace reposition tube without surgery. Then also discontinuation. At some point, they would have to remove the tubes from the patient, so they also have that in here. So, okay, that's what you will have to do in your homework, is to check your papers, check what they say about the costs. Again, you may need to check the tables, but that will be it. Any question? So no questions? If not, I'll leave it to Valerio.
Oh, thank you, Luis. Just to answer to Terry's question about where you find, for example, information about intubation, that will be the NHS reference cost, which Luis was providing the link in one of the previous slides. For example, you can find all kinds of information about treatment services provided by the NHS. So, and yeah, if you click on the link, you will be able to see that. Now, I'm going to move very quickly to this last slide for today. It's about the currency and the price here. And if you think about, for example, having an international study where, you know, you got patients recruited in different countries, for example, in the UK, in the US, you need to think at some point about how to express the costs which are accrued in different countries. Now, of course, that could be explicit, for example, in the results tables. You could see there is a common currency which is used in the tables. Sometimes there is a specific sentence within the paper where the authors actually indicate we use, for example, US dollars for our common currency. Similarly, authors need to consider a common price here. Especially when you have costs which relate to different years. So you might have some hospital costs which are accrued, let's say in 2020, GP costs in 2021, other type of cost in 2022. So they all need to be converted into a unique price here. That could be called valuation year, and I think that's the term they use in the paper we're using as example. So there should be a sentence around also the price here used by the authors. And if you want to see how things are converted, how costs are converted, there is a link here of a cost converted we use in our studies to convert the cost across different currency and across different years. Thank you, Luis. So session 3 homework, as Luis was mentioning before, you are now we are going to ask you to fill in a table with info on the cost data from your own economic evaluation, so from the economic evaluation of your team. So similar to the exercise you did after session 2, and we're going to ask you to complete this task in the next couple of weeks by Monday the 24th. And next slide. Oh, thank you, Luis. So this is where you can find the document, as always, on your Teams page. You click on session 3 costs, and that will open the folder where you see a document with your name on it. You can open that document, and then you will see the table, which is similar to the table from session 2. It's a bit shorter this time, but as Luis was mentioning, it might be not that easy to find this information because unfortunately, not all the authors, not all researchers report things widely and explicitly, let's say. But here you got the type of cost data in the first column. The second column is about the question. So what type of information you need to collect, you need to extract from the paper. As I was mentioning, there might be no information, or it might be very tricky to collect, to extract information about that particular type of cost data. So don't worry. Just try to do your best, and if you can't find the information, don't worry at all. And you will need to extract information and fill in the last column. And all the cost data should be in the method section or in the results table of the paper. Okay, so try to check both. So this is it for today. So this is the end of session 3, and we will see you in a couple of weeks' time for session 4, which will be covering the outcome side of things. Now, if you have any questions, Luis and I think, are more than happy to stay for another 5 minutes or so to discuss things. But I just want to thank you, first of all, for attending today, and also for asking a lot of questions, which are really good and make us debate a bit more about things which are, you know, very, very key and very fundamental to economic evaluations. So thank you for engaging with this session. And but yeah, we will see you in a couple of weeks' time. Okay, thank you, everyone.